Good afternoon, everyone. Welcome to Breakwater's fourth Lunch and Learn. Just like in the past, today's presentation is going to be recorded. So if you know of anyone who couldn't attend this presentation or any of the previous ones, they can be found at Breakwater's YouTube channel, which we will put in the chat for everyone. Today's presentation is all about treatment, which it's a lot. So as you have any questions, please drop them in the chat. And we will answer those at the end of our presentation today.
Welcome to Winnebago Recovers virtual Lunch and Learn series, Opioid and Substance Use Response. My name is Hannah, and I am the project coordinator for Breakwater, Winnebago County's Substance Use Prevention Coalition. The purpose of this series is to equip our community with available resources and find ways we can work collaboratively and effectively to prevent substance use, ensure access to affordable and timely harm reduction and treatment services, and support a strong and vibrant recovery community. Treatment is defined as the management and care of a patient to combat disease or disorder. Although we can't go through all the available treatment options today, we'll be giving you access to the substance use and treatment guide to see all other services available in our county. Today, our panel consists of Carol Morak from Winnebago County Human Services, who will cover Winnebago County's assessment process and treatment services, Sandy Shaffer from Shaffer Counseling and Consulting, LLC, who will talk about dual diagnosis, and finally, Dr. Eric Smiltneek from Aurora Healthcare, who will speak on medical assisted treatment. Thank you all for being here. Carol, could you please introduce yourself and what Winnebago County's role is in assessment and treatment options?
Sure. So I'm Carol Morak. My title is the Clinical Diversion Program Supervisor for our Behavioral Health Department through Human Services. We have a building in Oshkosh and Neenah. Both locations do assess for substance use and mental health. And in May, we will have another site in Oshkosh that's going to be a satellite clinic that's going to focus primarily for our diversion clients. So in general, what we do as a county is we see clients who are under the 275% poverty level in need of outpatient care. And we'll also see people who are below the 400% poverty level for people who need inpatient resources. So we have them come in and do an assessment. If you want to go to the first slide. So they come in and they do an assessment, and from that assessment, we determine what level of care they're appropriate for. So Winnebago County does some in-house treatment. We do psychotherapy in-house and some outpatient for substance use. But we also contract with numerous providers throughout the state. So when somebody comes in, we let them know what level of care they're appropriate for, and then we share with them what providers we currently contract with under that level, and then they can choose where they would like to receive their services. The only part that gets a little bit tricky is trying to figure out, for those that work, what hours are going to work with them depending on their level of care and where they need to go. The other thing I had added to this slide is you hear a lot of people talking about the continuum of care. And what's important is just to understand that sometimes when you come in and you're assessed and we say, you know, you're appropriate for level 2, okay, intensive outpatient, let's say, your level of care needs might change depending on how you do in that level of care. So they might go up or they might go down. So you might need to be reassessed and then referred elsewhere. So we make sure we just keep an eye on that. And that's why we keep in contact with the providers that we refer out to, or if we're doing it in-house. You can go to the next slide, please. And then here at Human Services, we'll do individual, and soon we'll start up our outpatient groups again. And when we do that, regardless of what level of care people are really entering treatment, we just try to follow through with the 4 stages that we have listed. So we want to get them engaged with treatment, and then we focus on early recovery, what that looks like, maintenance, how to keep that going, and then really to tie into the community support, which you'll hear a little bit more about, I think, when Sandy talks.
Thank you, Carol. Sandy, can you please introduce yourself and describe what mental health and substance use have together and the importance of treating them both? You have to unmute. It's okay.
Thank you for that. Sandy Shaffer, Shaffer Counseling and Consulting in partnership with Collaborative Wellness. So just a little bit of history with myself. I worked at Nova for 15 years and then almost 2 years ago went into private practice. So one of the reasons I did that is because I saw the need to be treating both the mental health and the substance abuse on a continuum. So one of the things to note is co-occurring disorder or dual diagnosis is a diagnosis of having 2 or more either substance use disorders or mental health disorders in regards to a diagnosis. So there's a difference between substance abuse and addiction. So addiction is going to be someone who is going to use in a compulsive way, and it's difficult for them to stop, even if there are negative consequences. And the substance, the substance abuse is when the person who's abusing it typically finds that they can quit if it's becoming a problem or some other negative consequences. So one of the things is that about half the people who have a mental health diagnosis also struggle with chemical dependency, addiction, substance use disorder. They're all kind of interchangeable. Most recently, it is going to be labeled as substance use disorder. In the SAMHSA 2020 survey, they noted that among people with co-occurring disorder of substance use disorder and mental health issues, about half the adults 18 and older that were surveyed indicated they had a co-occurring substance use disorder and mental health issue. In the past year, they received either substance use treatment at a specialized facility or mental health services in the past year. So about half the people surveyed said, yes, I had treatment for one or the other, but only 5.7% received services for both. So best practice, of course, is for both of them to be getting addressed and dealt with in order for the person to truly heal completely. So one of the things that happened in early 2021 was Winnebago County saw a huge increase in overdose deaths, suicides. So part of the goal was to get people services without any barriers, just have something available, either people who maybe are trying to stay connected to other people, are curious, maybe they're in the pre-contemplation stage as far as thinking about maybe they need to make some changes, and to not have to, sit on a waiting list or to do anything beyond simply show up. So in April of 2021, myself and one of my colleagues were able to put together a dual group because we're both duly credentialed with substance abuse and mental health, and Solutions houses some of those groups. And Day by Day Warming Shelter is another site that we provide services at. So we're very grateful to have those places that are willing to open their doors to any and all who want to appear or to seek help. There's no cost, there's no requirements besides literally showing up. They can come once, they can come every time. We do have participants that started with us last April that are still coming once or twice a week and really enjoy it. So one of the things that is important with the treatment of the substance use disorder as well as the mental health is to make sure that we are connecting the two illnesses, treating them both, and really looking at the brain in regards to healing it beyond just what's immediate. So we do a lot of right brain activities. So our left brain is kind of our logical brain, and our right brain is more of our creative brain. So our goal is to actually bridge those two parts of the brain. And many studies have shown that the emotional right side of the brain is part of the stuck point when we're healing for substance use disorder. So we're really incorporating both. Talk therapy is fantastic, but eventually we need to engage both sides of the brain. So that is a big piece of what we do for groups in relationship to the dual diagnosis. At the Day by Day Warming Shelter, we originally did just simply drop-in services for anyone who was seeking one-on-one time regarding mental health or substance use. And then in October of last year, we started doing groups there as well, because we found that it's a different culture in the homeless community. Their needs are somewhat different. They're living very much in their survival part of their brain. So the way we attempted to facilitate individuals tended to be a little overwhelming for them. So we found that doing group with them is less frightening. And Day by Day has been generous enough to allow people from the community to come in and join those groups as well. So it's been wonderful to see that people from outside Day by Day are also coming to join in those dual groups that we're holding there. Overall, it's been really successful in those terms, as far as numbers, because everyone likes information on success. Overall, we provided about, someone's joining. We served 118 different people last year during our groups at Solutions. And it's facilitated twice a week on Tuesdays and Fridays from 10 to 11:30. The reasoning behind that and seeking that site for services was because then there is always a noon support meeting there, as well as they have peer support specialists that are also available to speak with the clients that maybe are struggling. So between those two groups, 1,450 hours of group therapy were provided, and it didn't matter age, insurance, circumstances, everyone was welcome, no questions asked, which was part of what we wanted to be able to do when there's an epidemic within a pandemic. So, and then from October to December of last year through the Day by Day, there were 32 different people that came to group and participated with 117 hours provided of group therapy. That was down a little because they had about 3 or 4 weeks there that COVID wouldn't leave the facility. So it put a stop or a delay on some of those group services. So Hannah, do you want me to keep talking, or what do you?
That was good. That was a great overview. For anybody who has interest in the co-occurring group. We did put the schedule in the chat. And as you're hearing about our presenters, please put any questions you have into the chat, and maybe people will have questions for you at the end. Sandy, thank you. Next up is Dr. Smiltneek. He is going to be talking about medication-assisted treatment. So introduce yourself and please give the group just a little background on what that is and what you're doing over there.
Sounds wonderful. So thank you so much, Hannah, and thanks Sandy and Carol for kind of setting up this topic. It's very good. I've worked with both Sandy and Carol quite extensively, so it's good to have some partners. And I know that there's a number of folks who are here who I know quite well or who know me quite well. So so it's always great to see some old faces and to see some new ones. So for those of you who don't know me, I've been in the community for since around 2009 and been doing addiction work since about 2001 when I did some work in Chicago. And what I've been primarily doing is doing medication assisted therapy as a primary care doctor, first with Theta Care and then most recently with Aurora. I've transitioned a little bit more into doing addiction medicine. I became addiction medicine certified in 2018 and kind of have that certification and sort of split off and did some more additional addiction services. And what I tend to work on is more of the medication surrounding addiction. Sandy kind of set things up nicely where she was kind of talking about the thinking brain versus the survival brain. I like that survival brain idea, Sandy. So so thank you for adding that in. So sometimes what happens to folks is that even though they're trying to think their way through the process, and they may have gone and gotten tools and things like that that they need, that that this desire to use drugs or alcohol is so significant, so severe that that it's really kind of in a survival process. So they may say, you know, I don't want to use, but I have to use. I feel like I'm compelled to use, despite everything I know that's going to be bad. That we need these things. So so there's a number of medications that are useful for treatment, and they kind of get termed under. There's a couple of different terms that are used. MAT or medically assisted therapy is one. ORT or opioid replacement therapy is kind of another one that kind of get tossed around, and they're kind of universal terms. And I like to sort of think of it as just as medicine. So that I don't prescribe these medicines in any way that's really significantly different than I would prescribe a medicine for somebody who has asthma or prescribe a medicine for somebody who has diabetes. We prescribe the medicines, we take a look at the response to the medicines, we do some testing to see if they're compliant or using the medicines in the proper fashion, and then we adjust the medicines as needed, either up or down, depending on how things are going. So so just like somebody who has diabetes, there are some people who can make some significant lifestyle changes and may not need medicines for a long period of time. There are other people who these end up being kind of lifelong medicines for, and I think that sometimes becomes kind of hard for folks to kind of gauge or understand, to be like, well, so I had this problem, I want to get rid of it. It's kind of like they think of addiction as like a cold or something. That, okay, I have the cold, but I can get over it, and then I'm going to be fine. And it definitely is much more of a chronic disease that sort of requires sort of chronic management. And this might not mean that you need to be on meds forever, but there are some people who definitely benefit from meds and who do poorly when they're not on meds. And there are some times too where people find that the meds feel like they may be in conflict with some of the work they're doing, maybe some of the work they're doing through like AA or NA or stuff like that. And I have a gentleman who's really, really involved with kind of NA models and things like that, who's been on a number of different medicines for his opiate use disorder, also has some problems with cocaine use disorder. And with him, basically we'll have him on the meds for 6 months or a year, we'll taper him off those meds, he'll do poorly, will get back on. And it's not that his commitment to his program is any different. It really is that his disease process is so strong that survival brain instinct just turns back to those drugs if we don't sort of provide the medications that we need. So not all substance use disorders have medicines that are FDA approved, but there are a few that are approved. The most commonly used medicines to treat substance use disorder are the nicotine products. And actually most doctors are fairly, and nurse practitioners are fairly comfortable with these meds, prescribing them. There's nicotine replacement products. So things like nicotine patches, nicotine gums, lozenges, those types of things. There are nicotine meds that help with impulse control. There's one called Zyban or bupropion that's fairly useful. And there's another one called Chantix or varenicline. And that one is more of a nicotine blocker. So that's sort of a paradigm of a disease process that people are somewhat more familiar with and tends to be a little bit less stigmatized. Also has a lot broader use. The nicotine replacement products, you can buy those over the counter. So there's a lot less barriers and stuff like that. And what we've really seen is that probably 20 to 25% of people who want to quit nicotine use will be able to quit with these nicotine with some sort of medication, whereas it's more like 12 to 15% are able to, or 10 to 15% are able to quit without any of these products. So it's not everybody can quit with these products. I'm guessing a lot of people know people who have tried to stop smoking and have struggled with it. So they're not magic, but they basically double your chance of quitting or double your chance of not using these substances. So I think that serves as kind of a good paradigm of, well, what can medicines do if we're trying to use them, how are we using? So it's not that the medicines are going to drive Sandy out of, or Carol out of business. No, there's still going to be plenty of business for those folks, and we share. But a lot of times, what I'll talk to patients about is that it's just going to increase your chance of getting to your goals of either not using at all or potentially using less, depending on the substance. So the two main substances that I usually deal with surrounding meds are, one is alcohol use disorder. There are basically 3 medications that are useful for that. One of them is called disulfiram or Antabuse. This is probably the one that's best known. It makes you sick when you drink. The second one is a medicine called naltrexone. It's available in 2 formulations, a once daily pill and a once monthly shot. The once monthly shot is called Vivitrol, which people may have heard of in the opiate context, but it can be really useful in alcohol, especially in reducing sort of some of the harmful binge drinking that is very, very common in the state of Wisconsin, in case you didn't know. And then thirdly, there's a medicine that helps kind of on the anxiety aspect, which is Campril or a Camprosate. So those are sort of the 3 FDA approved meds that we use for alcohol. And then there's a couple other ones that we use for opiates. So for opiates, there are 2 in what we call the opiate replacement products. So not much like the nicotine replacement products. These would be methadone, which is a long-acting full opiate antagonist or full opiate. And then there is buprenorphine or Suboxone, which is what's called a mixed opiate agonist antagonist. And what that means in English is that it has some blocking abilities, but it also has some opiate satisfying abilities. The last one is kind of the antagonist therapy. So this is much like the Chantix or varenicline for the smoking, and that's that Vivitrol or naltrexone med. So you may have noticed that there's Vivitrol and naltrexone will overlap both for alcohol and opiates, which there are a lot of people who have problems with both of these. So that's kind of a nice thing. The naltrexone really works on the opiate receptor. So it's a much stronger med for opiate use disorder than it is for alcohol, in my opinion. But that alcohol has some effects where it does kind of hijack the opiate receptors. So we know that this happens and that it seems as if the Vivitrol is helpful for that. So those are kind of what we use for kind of common medicines. Unfortunately, there aren't a lot of doctors who prescribe these medicines, but in some ways, and I think we kind of set up the talk like this, that a lot of times people will go to Carol, they might get referred to Sandy, then Sandy refers them to me. But it also can work the other way too, that there are a lot of the physicians in town know who I am, so they say, oh, you're having a drug or alcohol problem. They'll refer them to me, and then I'll say, well, I think we can do something with meds, but I think we also need to think about that thinking brain piece. And so that's where we sort of send them to Carol to potentially get some assessments, or in the meantime, then we may send them to Kathy or to Sandy and basically say, yeah, I think we really need to address this stuff. I think it is very important to look at the mental health and physical health, or the mental health piece and the addiction piece together. There's a really interesting study that they did that said, are alcoholics depressed because they drink? So if we have somebody who is a depressed person or a person who suffers from both depression and alcohol use disorder, and we say, well, which came first? Is it the person was depressed, so they started to drink and self-medicate with alcohol? Or is it that they're drinking so much that they're kind of down regulating a lot of their brain receptors, and they're just not, they just can't be happy because they're drinking too much. And there's a lot of psychiatrists out there that say, well, if you're heavily drinking, we're not really going to treat you because you need to take care of that alcohol. Or, and sometimes the substance abuse places may say, hey, we're really dealing with substance abuse. We're not going to really talk too much about your depression as long as you're not suicidal. And if you become suicidal, then maybe we'll send you somewhere else. So there's this kind of dichotomy of stuff. And what they did is they took a look at these people and they said, well, we don't really care what came first, but what we're going to treat you both is with an antidepressant, something called sertraline or Zoloft, which is fairly commonly known. And then we're also going to treat you with naltrexone. And we're going to put those two, and we're going to treat them together simultaneously. And what they did is it was a real nice study where they looked at, one person got a sugar pill. Everybody took 2 pills. Some group had 2 sugar pills. Some group had a sugar pill and an antidepressant. Some group had the sugar pill and the naltrexone, which was basically a impulse control med, and some group had both. And what they found, which was kind of interestingly, was that all the groups did pretty similarly, except for the group that got both. If they got both, they stayed sober 3 times as long than if they did any of those other ones. So if you treated the depression only, you treated the addiction only, or you didn't treat anything, those people all did kind of lousy. But if you were really treating both of them together, that was kind of the important piece. So a lot of times what we'll spend a bunch of times with is talking to people about their anxiety or about their depression or about their bipolar or even about their schizophrenia, and say, well, what are we doing here? Is your marijuana use, is your cocaine use, is your methamphetamine use, are those helpful? Do we have sort of things that we're trying to treat that we're not? And if we need to treat your ADHD, or if we need to treat your bipolar, let's do that. And in the meantime, we'll sort of access this therapy to use those things. And those are really the people who have been quite successful, is if we do all of that too. So I think there is a lot of my thinking where I'm doing sort of treatment of the substance use disorder with the meds, but there's kind of a reason that they put me in the behavioral health department when I went into the addiction, is because there's so much of that stuff that's co-occurring. Either that, or they just think I'm insane, and that's where I belong. But I think that's kind of a quick overview of some of the medicines that we have. With the methadone med, that's one that I don't prescribe. There's some special federal regulations around that. But we do have, I have a pretty strong partnership with our methadone clinic here in town, the Addiction Medicine Solutions. So if people do need methadone, we're able to kind of negotiate through that and figure out how do we kind of negotiate those meds together. So if people do have methadone questions, I have some answers for that too. So, but thank you.
Thank you, Eric. I think it's important to note for anybody listening, because one of my questions was, if I need treatment right now, where do I start? And I think you brought it up a lot, Eric, is just being able to say, you can go to Sandy, you can go to Aurora, you can go to Human Services. Do we want to continue to touch on that just a little bit? If I am, trying to search for treatment, where should I start?
I can answer a little bit, and then I'm going to actually defer it to Carol. So if someone comes to group and talks about how maybe they need more or want more, or we identify them as needing more, my first suggestion is that they go to Human Services as a point of contact. I know Theta in Menasha now does walk-in mental health substance abuse services or assessments of sorts. I know there's various places that do the outpatient piece of it. But because, as Carol noted, there's the assessment that needs to be done as far as we want people to be in the least restrictive continuum of care necessary. So that would be, again, to start with Carol. So the Human Services also has the ability to help others if they don't have insurance and they need to sign up for insurance and those types of things. So Carol, maybe you just want to talk about what happens if, say, I walk into Human Services and say, I need help.
Sure. So we do have walk-in services at both of our locations, Oshkosh and Neenah. So it helps out with both ends of the county. When you walk in, if it's something that's immediate, we have a intake specialist starting soon. So it doesn't matter if it's substance use or if it's mental health challenges that people have, they'll make sure you get to the right people to see. So in essence, we do that every day of the week outside of the weekends. So we can see them, and then if they don't have insurance, we can help them set up for some insurance. If they do have insurance, we can let them know what services are available to them in the community where they can go to get further help. Sometimes we have people coming in that don't really know exactly what they need. They just need to sit down and talk through some things. We do have some people who haven't even heard of medically assisted treatment. So we do a bit of educating with that too.
Thank you. We're putting up on the slide everybody's contact information. What about the question of wait lists and having, when we think of treatment, sometimes there is a long wait list. Can we talk a little bit about, why that is, and is there anything that can be done about that, or can somebody get in soon? Going back to your co-occurring group, Sandy.
Well, I can tell you that many agencies have wait lists. Sometimes it's still a delay based on bed availability. Sometimes it's based on clinician availability. I know one of the goals of doing the group that we do at Both Solutions and Day by Day is to provide that gap services. So if in fact people do have to wait a week or two or whatever it is to seek services, that they have something in the meantime as a support. So that's part of what that process is, so that they can have something. So I know, like Carol mentioned, there are some places that do walk-in services, but overall, wait lists are there just because there's so many people that need help, and there's less help than there are people that need it, really, in my opinion.
Yeah, it's a good thing, because obviously in medicine, there's all kinds of wait lists for a lot of different services, but we're able to get people who really need people in quickly. So I mean, I think for me, like I do, like I said, I do both kind of primary care and the addiction services. And right now, my primary care, I think, to be a new patient of mine in primary care, I just learned I'm booking out till June. So that's a 3-month wait list for that. But for our addiction services, we actually have, we're usually able to get people in within a week or two for sort of the medically assisted piece. And some of those kind of require referrals from outside sources. But like we have our intensive outpatient program, which actually does not require a referral. So some people who want to get into medically assisted treatment quite quickly will end up kind of setting up with that program with like the with kind of the desire to get into the medically assisted therapy. So that it is sometimes what's going on. What I've heard is that the addiction medicine solutions at the moment doesn't have much of a wait list. So that's nice that we have something in our community that doesn't have much wait list. The other thing is that we are kind of working with in our group with integration into the hospitals, into the ERs. So I can consult in those. So obviously if somebody's in need there, I can go see them in the hospital tonight or tomorrow. If they're kind of in need of that sort of emergency services. So people are overdosing, they're in acute alcohol withdrawal, those types of things. But it's a lot of the struggles that we have is kind of bringing those services together to the people that need them at the time they need them. So I think like that's sort of the whole big thing is, well, what do you need today? What do you need tomorrow? And what do you need to recover for a long period of time? And I think if we can kind of stack the services together, it may be that they don't need to see me today or tomorrow, but they need some sort of services, and maybe getting in to see me within a week or 2 or 3 is what's needed here. Or maybe they don't necessarily need to get into a place like Nova today, that it's maybe they need to get into detox today and figure out a plan to get into Nova next week or in a few weeks. So
Eric, what about if someone doesn't have insurance and they want MAT or something of the sort?
So yeah, so that's difficult. Luckily, the Medicaid products have been really good, and we accept Medicaid products. The Theta accepts Medicaid products. AMS accepts Medicaid products. So if we can get them into some sort of Medicaid type of programming, that's been good. We've been working on some sort of stopgap stuff with opiate grants and things like that. I know we do some grant work with the Department of Corrections that we're kind of working on renewing for people who are coming out of corrections who need services. But luckily some of that where people are able to apply for Medicaid when they're in corrections versus having to wait to get out and having this gap and things like that have been nice. But I think that does sort of remain sort of an issue or problem. And I think that's probably where Carol can really kind of help out with, hey, where are services provided, what's going on. But yeah, that definitely is a barrier for some folks with MAT. There are some cash paying providers that are out there that do a nice job. So sometimes people will look at those and say, oh, this guy's just out for a buck or stuff like that. I've worked pretty closely with a couple of them who basically they're like, yeah, I really care about folks, and what I've done is I'm not accepting insurance in order to keep my costs as low as they possibly can. And I'm trying to work with folks to do that so that they can work through that stuff. So there are some folks out there who do that are nice nice to work with as well.
So yeah, we have a question from someone in our discussion today. Sometimes the window of opportunity is only open slightly for folks who need services right now. What do you recommend for dealing with those waiting for services in order to remain crisis free?
Well, I think there's various things as a starting point. Obviously the dual group, but also peer support specialists, recovery coaches. I think Todd is even on here who runs the PRISM group. I know Solutions has a peer support specialist and recovery coaches now on staff. So that's a direct point of contact. I know part of what Solutions is doing and establishing is kind of this point of contact. So it would incorporate going into the emergency rooms if people go in there if they overdose, and various touch points to have that immediate availability to reach out to those that are suffering. And also, of course, the Human Service Department. I don't know if that answers the question or not, Hannah.
Thank you. No, it does. And we're going to get all those contacts that you just said in the chat. If people from those organizations are on here as well and want to say anything in regards to that, feel free to do so.
Todd just threw that into the chat.
Thank you,
Todd,
Todd.
do you want to talk how to get in touch with you guys or what that looks like?
Yeah, hi, thanks. Appreciate the opportunity just to let everybody know that we are out here. I mean, the number that I put in the chat line is a 24/7 number. You can call that number and you will get in touch with a recovery coach. And if that coach themselves can't help you immediately, they will take a name and number and have another coach give a call back as quickly as possible. And we also have office in Appleton at 500 West Franklin that is open 9 until 5 Monday through Friday. You can walk in and immediately sit down with a coach.
Thank you.
I'll speak,
Go
if
ahead.
you don't mind, I'll speak
Yeah,
for
go ahead.
Solutions real quick too. They're there, they have coaches. Matter of fact, they have 3 people at least trained at Solutions now as recovery coaches. So please access them too.
We are actually going to be having Solutions on our next Lunch and Learn next week as well. And then Todd will be on for Unity on our last Lunch and Learn, which is peer support. So thank you for chiming in. One last question I have for our panelists today. If you had a magic wand to improve treatment services in either our area or across the state, what would you change and what would the landscape look like? How could we make that a reality?
For me, that's an easy one. I would make more of them, and I would make sure that they're all dually diagnosed programs because we don't have those. And the ones that we do have, which you can't get into hardly ever, don't take state or federal funding. So that really cuts out a huge chunk of the population that really need help.
I echo that. More understanding doctors like Dr. Smiltneek, who are understanding of both the mental health and the DODA to prescribe the dual meds or work with the other professionals that help do that. He's good at that, and I don't always find that in the other territories that I work in.
Well, thank you, Donna. That was one of the things that I was gonna say as well was I think what we've kind of worked on, and there has been some good work on at different levels of trying to encourage more physicians to get more familiar with a lot of the medically assisted meds, because I think that would open up access quite a bit for folks who needed that sort of access. And I think going into kind of the recovery and housing thing, I did see in the chat there was kind of a question that probably was directed towards me about if there's inpatient mental health care at Aurora and Oshkosh. There is not. And I think part of that was kind of when the hospital was set up, that was unfortunately mental health is a money losing type of ordeal for the most part, unless you do it in a pretty significant way. So I think Aurora has kept where they had traditional mental health, but hasn't really expanded mental health. And I mean, I think there may be some models and things like that where it ends up being kind of a financial thing, but it ends up being, well, what services are we going to bring in, or how are we going to do this? And
Nope, it looks like we lost Dr. Smiltneek. Well, I did want to also say in the chat we had, I'm just scrolling to it, MJ Behavioral Health has some reasonable appointment times, a couple of emergent appointment slots set aside each week, and we'll be starting dual diagnosis groups as well. So we put the contact for MJM Behavioral Health LLC is in the chat as well. I want to thank all of our presenters, Carol, Sandy, and Dr. Smiltneek, for joining us today. A big reminder is that we have our We Heart You Recovery in Our Community event tomorrow. Well, you'll be able to see some of these treatment professionals there and have booths and have opportunities to hear them in breakout sessions. This is free to the community. It's from 1 to 5 p.m. at the Culver Center. So feel free, if you did not sign up and you still want to come, we are accepting walk-ins and everybody is welcome. Next week, we'll be covering recovery and housing, again, by joining the same link at noon. Thank you all again for joining us. Have a great rest of your week.
Thank you.